We'll begin this course by looking at a basic radiation safety introduction for radiographers. Radiation has existed since the beginning of the universe, and human beings have been exposed to ionizing radiation since the beginning of time. We are constantly exposed to cosmic radiation, natural background radiation, and man-made radiation. Today we will explore medical radiation, or low-dose ionizing radiation, used for imaging, and high-dose ionizing radiation used for radiation therapy treatment. The amount of radiation a patient is exposed to from an imaging test depends on the imaging test itself and what part of the body is being examined. Here we see some of the topics that we will discuss in our presentation of radiation risk for patients and occupational workers.
The picture. X-rays were discovered in 1895 by Willem Röntgen. In his honor, the Röntgen became the unit of exposure or ionizations in the air, with one unit being equivalent to 88 ergs. So that gives us the amount of radiation in the area, but how do we measure radiation entering our bodies? This is important to discuss as biologic effects are related to absorbed doses of radiation. Radiation absorbed dose, RAD, measures the deposition of radiation in any type of tissue, while radiation equivalent man measures human exposure, further taking into account the biological effectiveness of the different radiation types. 1 rad equals 100 ergs per gram of absorber. Multiplying rad dose by quality factor results in REM. Radioactivity is measured in Curie. Based on the rate of decay in 1 gram of radon, it measures the quantity of material that will output 37 billion disintegrations per second. Now let us convert these units to their international standard counterparts. Multiply Röntgen by 0.01 to obtain gray in air. Multiply rad by 0.01 to obtain gray in tissue. Multiply REM by 0.01 to obtain Sievert. Multiply Curie by 37 billion to obtain becquerel.
The Rem is one of the 2 standard units used to measure the effective dose, which combines the amount of energy from any type of ionizing radiation that is deposited in tissue, along with the medical effects of any given type of radiation for beta and gamma radiation. The dose equivalent is the same as the absorbed dose. When discussing radiation and quantities and dose, we use terms like Rem and Sievert, which were really approximations of each other. Rem is a traditional term used. Sievert is the modern term. So sometimes it seems like we're talking apples and oranges when we're really not. The difference between Rem and Sievert is size. It takes 100 Sieverts to equal the amount of radiation in 1 Rem. Notice that there is millisieverts as a measurement that we often use to describe the doses that we give patients today. We use the term Sievert as an equivalent to the traditional term Rem. The difference between a Rem and a rad is that Rem is equivalent dose and rad is absorbed dose. So when we take a look at the rad, just like we compare Rem and Sievert, we compare the rad or absorbed dose to the gray or the milligray when we talk about the international system of measurement. The large dose of 5 Rems, traditional dose, is equal to 50 millisieverts. This is the maximum permissible dose per year that an occupational exposed worker can receive. 1 sievert equals 100 Rems, which is 20 times the maximum dose for occupational workers. 1 sievert carries with it a 5.5% chance of eventually developing a cancer, which equates to a 94.5% chance that you will not develop cancer when you receive 1 sievert of radiation dose. Let's take a look at radiation dose and the expected effects. General radiation doses to the entire body and the expected effects are as follows. 0 to 5 REMs received in a short period of time or over a longer period of time, such as a year, cumulative dose, we don't expect observable health effects. If we receive a dose of 5 to 10 REM in a short period of time or over a longer period of time, it is also generally safe. We don't expect observable health effects. At this level, an effect is either non-existent or too small to observe. 10 to 50 REMs received in a short time or over a long period, we don't expect observable health effects. Although above 10 REM, the chances of getting cancer are slightly increased. When chances, we're talking about the probability. We may also see short-term blood cell decreases for doses of about 50 REMs or above 50 REMs received in a matter of minutes. 50 to 100 REMs received in a short period of time will likely cause some observable damage or health effects. Above 50 REM, we may see some changes in blood cells, but the blood system quickly recovers. Doses between 100 and 200 REM received in a short period of time will cause nausea and fatigue. Doses between 100 and 200 REM will also give you a greater chance of cancer if they're received over a long period of time. If we go from 2 to 300 REM received in a short time, it will cause nausea and vomiting within 24 to 48 hours, and you should seek medical attention. 300 to 500 REM received in a shorter period of time will cause nausea, vomiting, and diarrhea within hours. Also, a loss of hair and appetite occurs within a week. Medical attention should be sought for survival. Half of the people exposed to radiation at this level will die if they receive no medical attention. 500 to 1,200 REM in a short period of time is likely to lead to death within a few days. Greater than 10,000 REM in a short time will lead to death within a few hours. Today we're going to do a comprehensive review of the latest human data on the most critical question for radiation protection, which is, what is the risk of cancer from low-dose radiation? Low-dose radiation is what we utilize in medical imaging. Medical imaging is evolving at a rapid pace due to computerization and new modality design. At the same time, the quantity of ionizing radiation used to create images for diagnosis is being reduced. Many exams that used ionizing radiation in the past have been replaced by newer imaging modalities that do not use ionizing radiation, such as ultrasound and MRI. Radiation safety is a matter of risk versus benefits to the patient. As the patient absorbs a direct beam of ionizing radiation, and operators are only exposed to indirect scatter radiation, both receive minimal amounts of radiation. When a diagnostic imaging modality uses ionizing radiation as its source of energy, the imaging produced should be judged to do more good than harm to the individual patient. Radiation exposure, particularly in children, has been a bedrock concern in medical imaging and radiology for years. It has spawned both the Image Gently and Image Wisely campaigns, both of which are based on the ALARA principle. This principle states that we use as low a reasonable dose of radiation as achievable to accomplish the exam. Below 10 Rem, or 1,000 sieverts, which includes occupational and environmental exposures, risks of health effects are either too small to be observed or non-existent. Here we see a comparison of males and females over a lifetime that have been exposed to 0.1 grays of ionizing radiation. You'll notice that once they reach the age of about 50, the incidence of cancer rates are the same. Prior to the age of 50, females are more radiosensitive than males. The only thing we worry about with low-dose ionizing radiation that we get in medical image is the stochastic or probability of carcinogenic effects. Carcinogenic effects have been known practically since the discovery of radioactivity and since the first case of radiation-induced cancer was described in 1902. Another term associated with ionizing radiation dose is deterministic, or a threshold dose. Simply, the term deterministic, when applied to doses of ionizing radiation applied to biological tissue, means that there is a specific threshold dose with a specific type of biological damage associated with it. With medical imaging, we use low-dose radiation, so we're only worried about the stochastic impact, which means the probability of getting cancer. Does not mean you get cancer, it means the probability. And if you were exposed to enough radiation to get a cancer, the one that you would probably acquire first is leukemia, or cancer of the blood, and it would happen about 15 years after the initial exposure. Other cancers take from 15 years to 60 years after exposure to appear. Under some rare circumstances of prolonged high-dose exposure, X-rays can cause adverse health effects, such as skin erythema, skin tissue injury, and birth defects in utero. Remember, this is high-dose exposure, not the low-dose exposure we use in ionizing radiation for medical imaging. The body responds differently to high-dose and low-dose radiation exposure. We use low-dose ionizing radiation exposure in medical imaging and high-dose radiation exposure in radiation therapy. The two methods in which ionizing radiation can damage a cell are direct and indirect, which we'll go over next. When ionizing radiation strikes a cell, it can cause damage either through direct or indirect action. The direct action causes a breakage in the spiral helix of the DNA, and an indirect damage causes a chemotoxic reaction or chemical reaction that damages the DNA. A damaged cell may repair itself, or it may die, and lastly, it may mutate. The mutation is what we worry about as a carcinogenic effect. If the cell is repaired or the cell dies, there is no carcinogenic effect. We are constantly bombarded by cosmic radiation, natural radiation, and man-made radiation. To give an idea of how much radiation we are actually exposed to, radiation from within our own body gives us about 40 millirems of exposure a year on the average. This comes naturally from the radioactive potassium that's contained in the body. We can also see potassium and other radioactive materials contained in the food we eat, such as a banana has about 0.01 millirems of radiation exposure from potassium contained in the fruit. Do we have large amounts of potassium in our body? Let's take a look. On average, 0.27% of the mass of the human body is potassium, of which 0.021% is radioactive. So no, we have a very small fraction of radioactive potassium in our body. Medical imaging uses low-dose ionizing radiation to create diagnostic images. We'd like to have you, end of the day, understand the effects of low-dose exposures, those exposures that are generally less than 100 milligray, and what these exposures do to our bodies and how they absorb in our bodies and what are the biological effects, if any. The biological effects of radiation are cumulative, so we'd like to take a look at the cumulative effects of radiation in a time perspective. First, we'll take a look at the time scale from fractions of seconds to generations, and then we'll look at the biological effect that corresponds to the time. You'll note from our previous slide that the biological risk to humans from ionizing radiation at low dose is extremely small, and there is a greater effect biologically if we get an acute dose, which means all at once, as opposed to a number of doses over a longer period of time. If the interaction of ionizing radiation with a cell damages the nucleus, what we can find is that the cell will normally repair itself or die. If it does not, it can alter the base sequence of the DNA, causing a mutation, such as cancer. The probability of ionizing radiation interacting with a cell's DNA and damaging the DNA is extremely small. Most of the information we have is extrapolated from the population-based cancer risk estimates associated with the Japanese atomic bomb survivor lifespan study. A neoplasia is an abnormal cell growth, and this abnormal cell growth or neoplasia may be benign or malignant. The difference in benign and malignant is that benign has a slow growth, it's non-invasive, and it does not metastasize. Conversely, malignant tumors have rapid growth, they invade and destroy tissue, and they have the potential for metastasis. What is the catalyst for a cancer to occur? We have over 100 different types of cancers, and we have many different catalysts or starting points for each cancer. Some of those being viruses, such as HPV for cervical cancer, bacteria like H. pylori for gastric cancer, and chemicals for lung cancer. We also have ionizing radiation, ultraviolet and ionizing, for skin cancer. So again, we can get cancer from many exposures and different sources. Low-dose radiation used for medical imaging is unlikely to be a large cause of cancer. This slide shows the effects of ionizing radiation exposure on tissue. It shows the effects of both low dose and high dose. Know that the stochastic effect is associated with the dose in radiation used for medical imaging, or low dose. The other effects are associated with high dose radiation exposure, such as the deterministic effect, where we know that where there is a threshold dose that correlates with a specific type of damage, such as cataracts, and we know the sensitivity of the different tissues that we are interacting with. We also have a teratogenic effect, which is on the fetus. A high dose of radiation to the fetus can cause mental retardation or malformations. For years in radiology, we taught that 1 photon of ionizing radiation energy can interact with a cell and cause damage to the DNA in the nucleus of the cell. The question we really need to ask is, what is the probability of this happening? Obviously, there is a very small probability of this happening with low-dose radiation and a higher probability with high-dose radiation. The cancer risk into some sort of perspective here. We know that the probability of a cancer begins at about 200 millisieverts of exposure, or 20 rems. As an occupational worker, you are never going to get exposed to that much radiation at one time or over a year. If you use 100 millisieverts as a milestone, which is half the threshold dose that we assume cancer could probability begin, we still end up with more radiation than you would occupationally exposed. What am I talking about? Think about it. You're able to get 5 rems or 50 millisieverts per year occupational exposure maximum dose. So what we're looking at here is that there is a very large cushion which is below the probability of any exposure causing cancer with radiation, ionizing radiation in diagnostic imaging. In another module, we'll look at some of the models for radiation and dose. And one of those models is the hormetic model. When we talk about low-dose radiation, low dose does not cause, but more likely helps prevent cancer. There is the hormetic effect, which actually small doses of radiation help the body to fight cancer. The average background radiation that anyone receives is 360 millirems per year. And this is from radon, internal emitters such as potassium, cosmic radiation, terrestrial radiation, and man-made radiation. Unless the physician is actively involved in the procedure, such as interventional fluoroscopy or doing surgery with fluoroscopy, the technologist is the determining factor as to how much radiation exposure the patient receives. Because medical imaging involves ionizing radiation that can deposit energy in human cells and cause tissue damage, it is important to minimize any associated risk to the patient. This is done by limiting the radiation exposure to the minimum required to create the clinical image and collimating the exposure to the area of interest. As a radiographer, you are occupationally exposed to ionizing radiation. During the radiography, the operator should be behind a protective barrier. These barriers are usually considered as secondary barriers, so protection would be from the tube leakage and from scatter radiation emanating from the patient. The tube should never be pointed toward this type of barrier. Staying behind the barrier effectively eliminates the source of occupational exposure if the shielding is adequate and no PPE or lead vests or lead aprons and etc. are required. There is no shielded control room when the tech is working with fluoroscopy, such as interventional procedures in surgery and fluoroscopic procedures in medical imaging, and also for portable radiography. This is when the tech needs to wear protective gear. The radiographer must understand radiation safety and the use of time, distance, and shielding to protect themselves when doing portable examinations or fluoroscopic examinations. Who is actually occupationally exposed with ionizing radiation and medical imaging? Actually, occupational radiation monitoring is required if there is any likelihood that an individual, whether they be the radiographer, a nurse, etc., will receive more than 1/10 of the yearly recommended dose, or 5 Rem. The Occupational Radiation Monitoring Reports. State and federal regulations require that the results of the Occupational Radiation Monitoring Program be recorded in a precise fashion and maintained for review. Specific information is required to be on the report, including current and cumulative exposure doses. Each site of monitoring must be identified separately. There will also be a control monitor to measure the background exposure during transport, handling, and storage. We'll discuss protective shielding and apparel in another module, and the care and design of the apparel and shielding. For now, we will simply state that during fluoroscopy or portable imaging, the operator of the equipment should wear a lead apron of 0.5 millimeters lead equivalency, because remember, we have lead aprons, we have non-lead aprons, and we have compound aprons. What we're interested in is how much ionizing radiation will they absorb. They must be worn when in a room during the exposure or during fluoroscopy. If the apparel has the equivalent attenuation of 0.5 millimeters of lead, 99% of the beam at 76 kVp will be absorbed. Now, remember the important part. The radiation that the occupational worker is going to be exposed to is Compton Scatter, which is emitted from the patient. And there is a very, very low amount of scatter emitted from the patient. Using the inverse square law, we can reduce by a rule of thumb to 1/1000th the primary beam exposure by simply being 3 feet or 1 meter away from the ionizing radiation that's being emitted by the patient. This is in addition to wearing the protective apparel. The most exposure occupational workers will receive is usually in an interventional type of room, such as cardiology or special procedures, where they're doing fluoroscopy, and the occupational worker should wear a wraparound type of protection, and a thyroid shield may also be worn. Lead gloves can be worn when the hands are in the beam, but remember, we should never put any part of our body directly in the beam. Aprons must be stored on a specially designed rack or laid flat. They are never folded. Aprons are tested annually for cracks or holes in the lead. Usually this is done by fluoroscopy. Repeat examinations. We think today with the digital imaging, because we have automated exposure control, that we don't have repeat examinations. When we analyze our images, we need to be able to understand the indicator numbers that come up with the image and how they correlate to the exposure being proper or improper. When we had film screen, we noticed that we used to have an average of up to about 5% normally of exams being repeated, and some exams or different hospitals or clinics had a higher rate than that. With automatic exposure control, we really don't see that in digital imaging, but we do have guide numbers that will let us know if the image was done correctly. If it doesn't correspond to the number that it is supposed to, you need to analyze the image and repeat it. Repeat examinations are generally due to positioning and motion. Just because we have automatic exposure control does not mean that we've made the proper exposure. You need to analyze each image that you take and correlate the exposure index number to a proper exposure. If the index number is not correct, then the exposure needs to be repeated because we don't want to miss pathology. This ends part 1 of the radiation safety modules. We have a number of modules which can be looked at individually or all together.